we go. All right, so let me get through these intro slides that just tell you what we're doing. Let's get to it. All right, so just a recap of chapter 6. If you guys haven't seen it in a while, we are going to be talking about the musculoskeletal system tonight. So that's going to be your bones and your muscles, the muscles typically that you have control over. So if you are the fitness guru type that goes to the gym, works out every day, that kind of thing, the muscles would be pretty easy for you, right? Knowing about your biceps, your triceps, your quads, hamstrings, all that stuff. The bones are a little bit more difficult for people unless you've been taking classes in anatomy or that sort, but they're pretty easy to remember too. We only need you to know the long bones. I don't expect you to name all the carpals. We just need you to know where the carpals are, that kind of thing. But our musculoskeletal system allows us to have a form, so we're not just a puddle on the ground or a pile of organs. We can stand upright. We have the ability to move. And ultimately, that's our main, that's how we thrive, right? You have to be able to get out. If you look back at how we used to be, we had to go out and hunt our food. Most of us still do. Now we use our legs to get us to the buffet line, but it's still, that's what we do, right? We have to be able to move. We have to be able to protect ourselves, not just from threats, but also from 2 a.m. stubbed toes on the way to the bathroom. So our system, this system is designed to protect our organs, obviously not the toes, but your ribs protect your heart and lungs. Your abdominal muscles protect all of your abdominal organs, that sort of thing. So your system is made up of bones, muscles, tendons, cartilage, and ligaments, but they can all still be damaged. We're not really designed to take car wrecks very well. It's just not in our adaptation over the years. Can anybody tell me the difference between a tendon and a ligament? I like having y'all talk to me. Anybody? Come on, y'all. It's a class. It's okay to be wrong. Got a text answer. So the question was, can anybody tell me the difference between a ligament and a tendon?
Yeah, a tendon serves to move the bones or structure, whereas a ligament, it's connective tissue that attaches bone to bone.
Perfect. Okay. Yes. So your tendons connect your muscle to your bone. Your ligaments connect your bone to bone. So you'll have a ligament between your tib fib and your femur, for example. You have ligaments that hold your patella in place. You have tendons that connect your bicep to your humerus or your tricep to your humerus, that sort of thing. So that's a real big difference there. Something I want to go ahead and point out while I'm thinking about it, because I don't think it's in the slides. When we're talking about healing time, and Keo, those of you that are in more of a facility-based setting, you guys already know this. There's much less blood flow to a tendon and the ligament than there is to the actual meat of your muscle. So if you get injured there, it takes a lot longer to heal, right? It also will hurt for a lot longer. So you may have patients that they probably won't call 911 for you, but they may point this out if they're hurt from something else and they tell you, well, you're getting your history from them and they're like, well, I hurt my leg a long time ago in the joint, in the knee, and it still hurts and I don't know what's going on. I think that maybe something's wrong with me and I'm not healing as fast or whatever. It's because those particular tissues take longer to heal. I've had that where somebody has kind of tacked that into their patient history and it's not really related to the call, but that'll be something that you can actually coach your patient on and just say, hey, yes, you may be hurting for upwards of a month or more trying to get rid of that tendonitis or whatever it is that you're complaining about. Musculoskeletal injuries are among the most common reasons why patients seek medical attention. Kind of depends on where you're at. If you're talking about trauma, which is what this chapter is in, yes, right? When you're in a car wreck, nobody calls 911 and says, my spleen hurts, We don't think about that. But if you break a bone, you'll definitely call 911 for that. These are the most distracting injuries that you're going to see. They usually come with pain. There's always swelling. That's just part of the recovery process. But don't let them distract you, right? When you show up, let's say you show up to that car wreck and you've got 2 broken legs, a broken arm, a twisted up finger, and all these things. And they're like, I can't feel my legs. And they're kind of mangled up. Don't let those broken legs and broken bones be the distractors, because remember, all the chapters leading up to this, you guys have learned about the things that really matter more, right? The spleen may be injured. The liver could be injured. What about their heart and lungs? Those life-sensitive organs. We as instructors and evaluators, really the evaluators, in trauma, we love to give you guys scenarios that have a lot of broken bones in them, because everybody wants to jump on that. But there will usually be something more primary assessment focused that's in there. So heads up on that. You know, if I tell you, all right, you showed up on your scene, you got a patient with 1 broken leg and another one, you know, his foot's over on the other side of the room or something like that, you should be worried about hemorrhage control and then ABCs. Don't start worrying about broken bones. Usually that stuff is fixed in the truck on the way to the hospital. So we have 3 types of muscle. We have skeletal muscle, which we're mostly talking about tonight. Smooth muscle, which is our blood vessels, our intestinal tract, the bladder, those kind of things. It's muscle we don't have active control over, but usually lines our tissues. And then you have your cardiac muscle, which I'll give you 3 guesses as to where that's located. You probably only need 1. Hopefully, at this point, you only need 1. Let me ask you this. I already mentioned that we can't control our smooth muscle. Can we control our cardiac muscle directly? Nope. No, we can't. Can we control it indirectly? Okay, so I got a no and a yes. Okay, there we go. Yeah, Keo got it. So yes, you can technically control your cardiac muscle indirectly. You can't just say, I'm going to make my heart beat faster, you know, beat heart, that kind of thing. But what you can do is obviously, you know, you speed up your breathing, slow your breathing down, go for a run. You can do things that will indirectly cause your heart rate to pick up. So when we talk about involuntary muscle, you can indirectly do some stuff like that, but generally you don't have direct control over it. That's also, but when we talk about voluntary muscle, that's skeletal muscle. And those are your main muscles that have names like the bicep, the tricep, the calves, the lats, blah, blah, blah. Like I said, anybody that's been in the gym, you probably know all of them. Those of you that are just going through EMT, I only really need you to know the main ones that are involved in movement. So the bicep, the tricep, the hamstring, the quads, the calves. And as far as muscles go, that's sorry. Everybody on Pass Road wants to rev their engines today. Those are the muscles that we're going to really use as landmarks. Muscles like your delts, your pecs, all that stuff. Those are involved in movement, but they're not the ones that are mostly hurt. So if it takes you a while to learn those, that's all right. All right, so we already talked about this. And remember, your voluntary muscle is connected to your bones by ligaments. I'm sorry, by tendons, not by ligaments. Your bones are connected to other bones by ligaments. You usually have a lot of nerve endings and blood vessels that go to your voluntary muscle. So with that being said, if you were to actually sever a muscle or cut it, something of that sort, you're going to have a pretty good amount of blood loss. They're also going to have a lot of pain. If you have a patient that tells you that they're hurting, we'll say they're hurting in their stomach. All right, like, oh man, my stomach hurts. If it's muscle, because there are so many nerve endings there, they'll be able to point to it and say within like a half an inch, it hurts right here and nowhere else. That's a sign that they're actually having a muscle pain if you're trying to figure that out when you're talking about abdominal pains. Earlier in module 3, we talked about the deferred pains like heart attack radiating down the left side, kidney pain hurting around in the flanks, that kind of thing. The reason that is there's less nerve endings. And so the nerve endings are further away picking that up. So in this case, when we're talking about skeletal muscle or voluntary muscle, whatever you want to call it, their pain is much more sharp, much more focused. It doesn't spread out. It really doesn't defer anywhere. That's a good way for you to figure out what kind of, like, where's the pain coming from? What's the problem with my patient? All right, smooth muscle, mostly for think like your blood vessels, your intestines, that sort of thing. So with that in mind, with this picture you see on the slide, most of your smooth muscle is round and there's a hole in the middle of it. There's some exceptions to this rule depending on where you're talking about, like the bladder, for example. But if you were to take a cross section of smooth muscle, this is what you would see. And they're basically donuts that allow themselves to either open up or constrict down so that we can vasoconstrict, vasodilate. If you're talking about your digestive tract, then it's what allows your body to do that pushing motion that pushes the food through your digestive tract, that kind of thing. These are also very rich in blood supply, but again, we don't really control them. There's not a lot of pain receptors to these. There's not a lot of motion type nerves in this area because we don't have active control over it. And then cardiac muscle is specially adapted involuntary muscle with its own regulatory system. One cool thing about cardiac muscle, if you take away the SA node, if you take away the AV node, if none of that stuff works, the individual muscle cell itself can still create a heartbeat. Our hearts are pretty resilient, but the cardiac muscle itself is not good at it. So you'll be able to tell, you check a patient's pulse and it's down around 40 or less. That pulse is probably coming from the heart muscle itself, and they won't last long. So that's not a good thing. It's cool that they can do that, but we never really want to get to that point. Our skeleton gives us our recognizable human form, protects our vital organs, at least most of them. It allows us to move, allows us to pick up weight. There's 206 bones, but you don't, like I said, you don't have to know all of them. In fact, you probably, if I had to count it, 3, 6, 9, 12. Yeah, probably 15 bones by name. Maybe 4 or 5 bone groupings, and then that's about it. So EMT is not real strong on the anatomy side for this, which is good. You shouldn't have to learn all 206 bones. They produce blood cells, red blood cells in particular in the bone marrow. They also produce white blood cells, and they serve as a reservoir for minerals and electrolytes. I know this is out of your scope to do it, but can you give, or can somebody give a patient fluids through their bone? Is that possible?
Yes, through IO.
Yep, through an IO, which stands for intraosseous. So that's not something that you'd be able to do as a basic, but it's good to know that you can. All right, not an IV is not the only route that somebody can get fluids. That's our preferred route, but it's not. That's not all there is out there. IOs are good. They're easy. They're good in an emergency. Sometimes they're a lot easier to get than an IV, especially in like a cardiac arrest where the veins are flattened out because there's no pressure. If you've got, I would say a new paramedic, but really new paramedics are pretty good with the IOs because it's in the school. So if you've got a really old paramedic, their training may predate the IOs. So maybe something for you to remember and mention to them if you're ever in that scene. All right. So real quick, we have our upper extremities, lower extremities, your pelvis, and your shoulder girdle. That's going to be the big thing here, for your appendicular skeleton. Now, I want to point out while we're on the slide, your pelvis is supposed to be one solid piece. Every time you go to check the pelvis in a patient, when you're looking for bone breaks, the pelvis should not move independently like one side from the other. That's just not how it's built, right? We have to have that stability. So when we do our skill days this weekend and you're checking for bone breaks, I want you to think when you grab their pelvis, you're going to grab them by the hips, just a little bit below where their belt would be. and you're going to push your hands in together, like you're trying to clap your hands, and then you're going to push down to the floor. So it's only 2 movements. I want you to get used to that now. I'm putting it in here so you can be aware of that when you go to do your skill day. There's a lot of blood that is stored in the hips. And to the point where, like, if it's an elderly patient that falls and breaks their hips, they could die from blood loss, just internal bleeding, and you'd never see a drop hit the ground. So when y'all are checking this, it's just 2 movements. You press them in, you push down. You should not feel any difference in motion. It should be one solid piece. Skull protects the brain. The thoracic cage protects the heart, lungs, and great vessels. And a note on the ribs, they're shaped like the letter C, and they angle down. So all of your blood vessels, your nerves, all that stuff, they technically run underneath each rib. And that being said, if you break a rib, have y'all learned flail segments yet? Or is that in this chapter? I get confused. I forget. I know sometimes I think flail segment may be in the chapter that has the lungs, because that's what they're a threat to. But I'll go ahead and recap it. A flail segment is, let me go back a slide. So a flail segment is where you break a couple of ribs, like 2 or more ribs in 2 or more places. So you've got a chunk of your ribs that are completely disconnected from the rest of the rib cage. Obviously, we're concerned with broken ribs about punctured lungs and that sort of thing. But I also want you to keep in mind about those blood vessels that run underneath there. If you have a flail segment, there's a real good possibility that the break also severed the blood vessels and the nerves that run through there. So they're going to have numb spots where they can't feel. Okay. Yeah. If you want, tell you what, just wait for a break and then ask. That way you don't have to wait till after class. But and so if the rib cage has that break in it, you may be having blood pool into the chest. So you're going to get blood in the chest. What is that called? Very close. Yeah, if it's just blood, then it's going to be a hemothorax. So if like I said, if you have a flail segment, it severs the arteries. Now you're bleeding in the chest. That's a hemothorax. Hemopneumothorax would have, pneumo means air. So if that flail segment pops a lung at the same time, then yes, you'd have both hemo and pneumo. So excellent attempt. You almost had it. Just the pneumo wouldn't apply. All right, good job. All right, so for your arms, they connect into your shoulder girdle, which is called the rotator cuff. It's I think it's 3 different bones that fit together, and you have a couple of muscles that allow the arm to move in a 360 degree motion. If you look, the head of the humerus fits into the shoulder. All right, it's not the other way around. It's not that the shoulder comes out to the arm. That's what allows you to have that 360 degree motion. When we look at the lower body, the femur fits into the pelvic girdle the exact same way. And no, y'all don't have to know all these words. All right. The big thing here, obviously, know your sternum. That just is the breastbone. Clavicle. The clavicle is important because there's another artery that runs right underneath it. Can anybody tell me what that artery is? It's a major vessel. Starts with sub. Yep. Subclavian. And an easy way to remember that, going back to your med term, The subclavian artery runs underneath the clavicle. All right. So sub meaning below and clavian referring to the clavicle. Subclavian artery, you've got one on each side. They come directly off the aorta and they run down your arms. They become your brachial arteries. They are very large at that particular location. So if somebody takes a break to the shoulder or a flail segment really high in the rib cage, that subclavian artery is at risk. And actually, if anybody in this class knows Chief Bannister, the Poplarville fire chief, if you go to Poplarville and you ever talk to him, have him tell you about the time he went to set an IO, or not an IO, I'm sorry, he went to needle decompress somebody. And even though he was between the right ribs, he still hit their subclavian and they almost bled out on him. And I'm not laughing at that scenario. I'm sorry, I was laughing at a text. But it was a weird patient. That particular patient, their subclavian arteries ran a little bit lower and he didn't realize it. I mean, that's not something you typically see. He was wondering why, when he did the needle decompression, it started shooting blood and would not stop, to the point where he's like, I know there's much blood loose in the chest. What's going on? It wound up being that he hit that major artery. So that's a landmark for you. Not so much for that, because that's a paramedic skill, but just know that it's there. If you show up and somebody's like, yeah, I got hit in the shoulder and I broke my clavicle, suspect major internal bleeding if that artery is involved. Going down your arm, we have your humerus, that's your long bone in your upper arm. And then you have your, if you can see in the picture, your bicep and your tricep. In case y'all aren't sure, the bicep is on the top of your arm, the anterior side. It has two heads, hence we call it the bicep. The tricep is on the back side of your arm. It's got 3 connection points. That's why we call it the tricep. Don't get your ulna and your radius mixed up. Remember, we checked the pulse, the radial pulse on the thumb side, right? So the radius, which is where that pulse gets its name, is going to be on the thumb side. The ulna is on the pinky side. Your hand contains 3 sets of bones. Again, I'm not expecting you guys to name all the carpals. Save that for your doctors because they have to know them all. But you have your wrist, which is your carpals, your hand, which is your metacarpals, and then your fingers are your phalanges. And you'll see when we get to the foot, the foot's almost the same. It's just going to be, instead of a C for carpals, it'll be a T. So tarsals, metatarsals, and then your toes themselves are actually phalanges as well. Not really going to dig too much into the pelvic girdle, the ischium, the ilium, and the pubis, because I think that's a little bit out of scope for an EMT. I just want you to know that that's supposed to be one solid piece. All right. Those bones are all fused together. They don't move. So when you're doing your assessment, if you feel movement, if you feel instability or something of that sort, that's a very bad day for your patient, and they should go to the hospital very, very quickly. And be very careful how you move your patient if that's what you see, which we'll get to in a little bit. All right, so your lower extremity, if you look at the top, you see that how your leg connects into your hip is the same design as how your arm connects into your shoulder, right? You have that ball and joint or ball and socket joint to allow for 360-degree movement. That is really the only spot that moves in your leg as far as around the hip. Your femur is the biggest long bone in the body. It's designed to hold the most weight, but it's designed to hold the most weight along its actual axis. So it's like standing up. All right. A lateral force coming at it from the side will break that bone despite how big it is. And again, being that it's such a large bone, you run the risk of losing a lot of blood. The other problem with this is you also have 2 major arteries that run down this. All right. So you have to be careful. Anytime a bone breaks, you run the risk of damaging the artery or the veins. The veins may not lose pressure very quick because they're low pressure, but the veins hold most of your blood. The veins act as a reservoir for most of your blood. So if you have a venous cut, it's not going to spurt out, but the amount of blood you lose is going to be major. So that's another thing to worry about when you have these bone breaks. Also, the muscles of the leg obviously are some of the biggest muscles that we've got for movement. Your femur has the quadriceps, which named because they have 4 heads, and your hamstrings are all tugging on different sides of this bone. So if you break the bone, if you break the femur, what do you think is going to happen to that leg? Is it going to shorten up or just stay the same length as the other leg? Yeah, it'll shorten a lot. One of the biggest issues with this is, imagine that you break this femur in half. Now you've got the muscles of your thigh pulling the two ends of the femur, the top and the bottom, together. And so the actual shaft of the femur is like having two knives stabbing in two different directions inside your leg. They're going to tear a lot of stuff up. So again, now you have even more damage, more bleeding. And if you, depending on what you sever, if you sever, say, the femoral artery, you could die. If you remember, if anybody has seen Black Hawk Down, if you remember that scene where the medic was trying to dig the femoral artery out of the guy's leg and it retracted because it got severed, that's what you would see here. And if it retracts up into the abdomen, there's nothing you can do. Your femoral arteries, they are huge. They basically, the aorta branches off and becomes them. So they're very large arteries. Right? Your tibia and your fibula is your lower leg. I want you guys to know the difference between the two. An easy way to remember which one is the load-bearing bone and which one is not. The fibula is feeble. All right, so feeble, like weak. In other words, the fibula does not support your weight. The tibia supports your weight. It's the bigger bone. The fibula is the one that helps you move your foot left and right. And then your patella is your kneecap. Down to the foot, we talked about how your wrist and your hand is called carpals. So for your foot, they're called the tarsals, the metatarsals, and then again, your toes are your phalanges. The bones of the skeleton provide a framework to which the muscles and tendons are attached. We already talked about that. They're attached by the tendons, and a joint is formed wherever two bones come in contact. So those can be the joints that allow us to move. Those are the easy ones, right? You have a joint in every finger. You got a joint in your knees, your elbows, so on and so on. But not all joints are movable. You still do have those joints in your skull. You've got those joints in your pelvis that allow, different bones are just fused together. But those are still joints, right? The ones that can move, though, they're held together by tough fibrous tissue, which we call ligaments. They're usually filled with synovial fluid for lubrication. And unless you've been in an accident or something of that sort, or maybe you're malnourished, typically your synovial fluid is maintained pretty well. You may have people that were in old motorcycle accidents, like yours truly, who jacked up his right knee. And I have scar tissue that I'm constantly having to work out in my leg so I don't lose my range of motion in my leg. So I won't harp on that too much. Just be careful when you're out riding my motorcycle. Significant force is generally required to cause fractures and dislocations. If you hit a bone along the length, you tend to be okay. The bones won't really break. They might break at the joint, but the bone itself, like say the femur, if you fall from a height, 10, 15 feet, and you land on your feet, you're probably not going to break your femur. That's because the bone is designed to handle weight in that direction. But what you might break would be your hips, right? Because your hips are not designed to take that kind of a shock. So you can have damage from direct blows like that. You can have indirect forces, which would be, like I said, if you landed on the ground, you land on your feet, the direct blow is actually to your feet, but that's not what you broke. You might have broke your hips. That would be an indirect force. The force wasn't applied to your hips, it was transferred to them. Twisting forces can break them, particularly our twisting bones. So your tib fib in your lower leg, your spine is actually meant to twist. That's the big design of that. Your radius and ulna, if you you twist your hand, you pronate or supinate your hand too far, you could break those bones. And then high energy forces in any direction. It doesn't really matter what direction. If it's high enough energy, you will crumble your femur. You'll break pretty much any bone. All right, so let's talk about fractures. Do all fractures come out of the skin? That'll be one question. Let me ask you that. All right, good. Yeah, no. No, and in fact, that's where you see on the slide where it says fractures can be open or closed. That's the difference between the two. If it's an open fracture, that means your bone is sticking out of the skin. A closed fracture just means it's not. So that's an easy classification there. How about this question? Does a fracture have to be a complete break in the bone, or can it just be a crack? Yeah, it can just be a crack. Displaced, are you referring to the joints, Keo? Like a shoulder dislocation?
No, more or less just like in the clinic, if we see there's like a hairline fracture, sometimes the doctor will refer to it as non-displaced because it's not separated. It's there. It'll heal a lot easier, or she'll call it displaced. So that's why I was.
Okay, I see what you're saying. Wow, I learned some new terms today. Yeah, but I see exactly what you're talking about. So if you don't completely break the bone, say like go back to the femur because it's a large bone, it's easy to talk about. If you just fracture the femur, but the femur is still pretty much in place, it's still in one piece, then it would be non-displaced. Is that correct? Versus
Correct.
if you
Yes,
were to
sir.
break it in half. Okay, awesome. Yeah, that's why I like teaching. I learn new stuff all the time. All right. But if again for this, if it's open, you're going to have bone sticking out of skin, or at least bone exposed to air. An open fracture of the skull, you may not see bone sticking out, but you'll see bone. Like that's an open fracture. And the pain of an open fracture goes way up as opposed to a closed fracture. If a bone is exposed to oxygen or air in general, it doesn't feel good. I've never broken a bone. This is just something that I've learned from other people that have. So if y'all have broken a bone, you could probably testify to that a lot better than I can firsthand. But bones exposed to air hurt really bad. A fracture hurts, a closed fracture, but it's a different kind of pain. I don't know if it's less pain, but it doesn't hurt to the extreme that an open fracture would. Oh, here we go. All right. So as you were saying, Keo, non-displaced fracture is a simple crack in the bone. This is the new addition, so I'm glad they put this in here. A displaced fracture produces actual deformity or distortion of the limb. So if you're looking at somebody's leg and you see hip, then you see knee, then you see second knee, and then you see ankle, that's one of those does not belong, right? That would be a displaced fracture or a really bad break. Here's a couple of examples. So in figure A, let me move this out of the way because I don't want to ask a question that's right there in the slide. Which bone is broken? Is that the tibia or the fibula? In figure A. Good job, Chrissy. You got it. It's the fibula. Yep. Remember, and this is because this is the lower leg. So you have a large bone and a small bone in figure A. So the small bone is not really designed to be weight bearing. That's going to be the fibula. That's the one that's broken in the picture. The tibia is the bigger of the bones. That's your weight bearing bones. So again, the way that I always learn to keep them separate is the fibula is feeble. Feeble is another word for weak. So the weaker of the two bones is your fibula. All right. A real quick, the big thing I want you to think about here is not so much comminuted or green stick, but I want to talk about the epiphyseal plate for a second. Has anybody ever heard of that term? You're gonna hear more about that when you get to the pediatrics chapter. So the epiphyseal plate, picture a long bone, like a dog bone or a femur, all right? As a 2-year-old or 1-year-old, we're not very tall, right? Our bones have to grow for us to gain our height. Now, if you picture the femur, because it's an easy bone to picture this with, you have your head on both sides, just medial of the head, where the, kind of like dogging or bookending the shaft, you have this epiphyseal plate. It looks like cartilage. Actually, it is cartilage. And that's where the new bone grows from. So as we grow up, as we gain our height, our bones are extending from that plate. All right. Now you can break a bone as a child and be fine. You'll recover. Everything's good. However, if the break actually hits the epiphyseal plate and breaks the plate, that epiphyseal plate will no longer develop new bone. So if that happens, if a child breaks their bone really close to the end, that's always a big concern at the hospital, because if the epiphyseal plate is broken, they're not going to get any more length out of that bone. They'll still get it out the other side, but they're going to lose that. And then, so that's going to be repeated surgeries over and over again as that child continues to grow, where they have to extend the bone. At least that's what they were doing when I was a kid. I don't know if they've got a new procedure now, but Keo, if y'all have seen that, by all means, let me know. But to my knowledge, if you break the epiphyseal plate, that's going to be a lot of painful surgeries for the kid as he goes into adulthood, if they even do anything about it now. They may just let it be what it is. We have incomplete fractures. That's going to be the typical, what you think about when you think of a fracture. It's like a bone break, but you didn't completely break the bone. So just keep that in mind. Complete would be a complete severance. You had one femur, now you had 2 femurs, now you got 3, because one's broken in half. Spiral fractures can happen by a twisting force. They can happen to any bone, but they usually happen to the bones that are designed for twisting, because we've over twisted. Something has happened that we've overdone it, and we have broken the bone in the process. But you can twist break any bone. All right, here's some of the gnarly pictures I was telling you about. This guy's right leg obviously is broken in some way. I don't know, don't have an x-ray on the slide, but you can definitely tell something's wrong there, right? His ankle's swollen, deformed, there's an issue. What is guarding? Anybody want to tell me what guarding means?
That's when the patient, that's when the muscle, I think, tenses up to prevent movement. I think.
Okay, it was a good guess, a good attempt. Let me ask you this. So, or you may have seen this. Anybody get hit in the stomach really hard, and your reaction is to kind of cross your arms in front of your stomach, like, ow, that hurt? That's guarding. All right. So if somebody gets hurt, they say they crack a rib. It's an instinctual thing for us to move our hands in front of our rib cage to provide protection where the protection is no longer there, because we have broken our ribs. So that's guarding. We tend to do it if we get hit in the stomach really hard, if we have a organ that gets hit, because we don't have any bones there, right? There's no protective bones below the diaphragm. So our arms kind of act as that in case we get hit. I see you're in the room, Chris. Are you good to go? If so, I'll get him through this slide, put him on a break, and we'll swap out.
Yeah, that's fine.
Okay. All right, so some signs of fractures that you'll see, again, when you're going through your assessment: bruising or contusions, which is the medical term for that. Crepitus. What is crepitus?
Grinding of the bones together.
Very good. So crepitus, you can hear it again in any bone, especially if there's a full break. But the main ones that we don't want to see this in, again, are going to be the skull, because there should not be any movement in the skull, right? So if you're hearing bone on bone movement like crepitus in the skull, that's a problem. Same thing with the hips. The hips, there's really no vital organ around the hips that we worry about. The hips themselves are the concern. because they hold so much blood. That's the big issue there. Again, if you crack a hip, especially the elderly are really prone to this. If they crack a hip and the amount of blood you lose, that could be death. And there's really not a whole lot we can do about it. So if you are checking your patient's musculoskeletal system and you come across that movement, you hear crepitus, do everything you can not to move that section. So we have scoop stretchers. We have all these different things that we can use to really kind of stabilize that so that that doesn't happen. All right. False motion, exposed fragments, which would be an open fracture, right? Pain, obviously, and a locked joint. So if a joint gets if a bone gets broken or knocked out of place, it'll lock the joint. Think like if you get hit in the jaw and you dislocate your jaw, you may not be able to open and close your mouth until it gets reset. That's kind of where they're going with that. All right. I know it's a little bit early. We're going to go ahead and put you guys on a break. Chris, how long do you want them to take? I'm going to hand it off to you.
Just take 10 minutes. That's cool.
All right. There you go. Let me hand you host.
I think I just took it from you, Rob.
Yeah, you did. That works. All right. I'm on, in case you didn't see it,
You're on slide 33.
33. Yeah.
All right. Thank you. Thank you, Rob. I really appreciate you.
No problem, man. All right, y'all have a good night. And I will see some of y'all Friday and some more of you on Saturday. Peace out. Oh, yeah. Rodney, what was your question? That's probably why you didn't have it in your skills, but if it's not something y'all can do in your state, they would have left it out in the skills day.
All right, folks, I don't know if y'all are all back. I don't even really remember what time I told y'all to go break, so I'm sorry. Uh, maybe I was a little off, but we'll go ahead and get started so we can continue. All right, so let's go over dislocation. So we see right there, it's a disruption of the joint in which the bone ends are no longer in contact. That's the definition of a dislocation. So it does support ligaments are often torn when there is a dislocation. It usually is completely allowing the bone ends to separate. It's just like breaking it and pulling it apart. We've seen that you may see some pictures out there of dislocations versus a broken bone, but a fracture dislocation is a combination injury at the joint in which the joint is dislocated and there is a fracture of the end of one or more bones. Kind of another textbook answer there. So kind of gives you some information of what to think and look about. Trying to get my notes pulled up so I can see. All right, so sometimes a dislocated joint will spontaneously reduce, but it means it'll fix itself. Or return to its normal position before you assess it. So you may get like a knee that's popped out of joint or a shoulder. Those are kind of the bigger ones that you happen to hear about. You'll be able to confirm the dislocation only by taking the patient history. A dislocation that does not spontaneously reduce is a serious problem, and it is commonly dislocated joints include fingers, shoulders, elbows, and knees. Some signs and symptoms of those. So you're going to have the marked deformity, you'll have the swelling, you'll have the redness. Obviously, the pain is aggravated by attempts for movement, which we try to splint it in place and don't move it. Tenderness on palpation. They'll tell you real quick, whoa, what you gonna do? Why are you trying to touch my arm? Well, I gotta feel it. Virtual complete loss of normal joint motion. So it is kind of locked in place. It is kind of like a fixed joint at that time. Numbness or impaired circulation to the limb or digit is found. Some sprains. Let's talk about that for a minute. I'm trying to pull up, my son's playing baseball tonight, so I'm trying to pull up Game Changer so I can watch him. I don't get to watch it all the time, so I'm trying. So sprains occurs when the joint is twisted or stretched beyond its normal range of motion, and it's on that break of urge of being a dislocation or a fracture. The supporting capsule and ligaments are stretched and torn. So sprains can range from a mild to severe strain. The most vulnerable joints are knees, shoulders, and ankles. After the injury, the alignment generally returns to a fairly normal position with some reduced swelling, maybe some OTC medications. Something to that effect will help with the reduction of swelling and or pain. So again, signs and symptoms, we're going to see that they're guarding it. They're going to not want you to touch it. You'll have the swelling and ecchymosis like you see in the picture right there. It is painful. And it's not like broken painful, but they don't, I mean, I think the majority of us is either sprained or broken or, twisted something out here. So we kind of understand that. So inability of the joint, it doesn't want to move. It's not a lock joint, but they don't want to move and get it all sideways. They want it to leave in a position to where it's not painful. They leave it right where it's at. So a strain is pulled muscle. It's a stretching or tearing of the muscle causing pain, swelling, and bruising of the soft tissue in the area. Unlike a sprain, no ligament or joint damage typically occurs in this area. Often a deformity is present and only minor swelling is noted at the site of injury. And most patients will have extreme pinpoint tenderness. So they can take their finger and point. Right here is where it hurts. That is how we know that it is pinpoint tenderness. They tell us that, they make sure that we understand it, and they can give kind of a better outline of what's hurting most when it's a pinpoint area. Obviously, we know an amputation is a removal. It's a complete severed part of the body. The injury can damage every aspect of the musculoskeletal system, from bone to ligament to muscles. This is a complete cut dislocation, severed, removal of a particular limb or body part. Some complications. Orthopedic injuries can lead to numerous complications, not just those involving the skeletal system, but also sympathetic changes or illnesses. The likelihood of having a complication is relatively small, but you see those three particular areas is where we're going to see some relative complaints. Injury location, the force that caused the impact, and basically the patient's overall health will dictate in the healing process. To prevent contamination following an open fracture, you should always brush away the obvious debris surrounding any type of open fracture before you apply any kind of direct pressure. Do not enter or probe the open fracture site. You can help reduce this risk by duration of the long-term disability, so try to get them faster to the facility, preventing further injuries, reduce the risk of wound infection, the faster we can keep it clean and or covered, and obviously transport your patient to the most appropriate facility. If we have an open injury and we transport them to a Band-Aid walk-in first aid clinic because it is an option, that is not the most it's not the most appropriate one that we should transport them to. Same thing there. You prevent further injuries, reduce the wounds. We talked about that. Assessing the severity of an injury. So we have this thing called the golden hour. It is critical not only for life, but also preventing limb availability. In an extremity within its anything less than a complete circulation, prolonged hyperfusion can be significant damage. Any suspected open fracture or vascular injury is considered a critical injury. Remember that most injuries are not critical, but in this golden hour from the time that we get there, from the time of the incident to the time that they're in surgery should be less than an hour. Now, granted, that's not always the case, but that is what we want to shoot for, is to have them in the facility, ready for surgery, prepped for a trauma team within the golden hour. That's what we want. Sometimes it may not happen. Sometimes it might. What's to say? Always look at the big picture, evaluating the overall complex of the situation, and determine life threats. You must also be able to distinguish mild injuries from severe injuries, because of some severe injuries may compromise your neurovascular function, which again could threaten your long-term functions. Things size up. What are we going to do? It's the same thing as everything. Determine the MOI. What are our standard precautions? Do we need to be gloves, mask, and gown, or does it need to be more of a complex approach to this? Think about any kind of unseen bleeding, what we see that's hidden, and evaluate the need for additional support or additional ambulances to help support our need that's on scene for what we have in front of us. Our MOIs, look for those indicators. What's yours say? Be alert for primary and secondary injuries. Know that we may have an initial one that appears to be life-threatening, but it's really not, like that evisceration. We just know we need to address it when we come to it. And consider what injuries an MOI could lead you to expect. If it is a rollover injury, rollover vehicle collision, note that you may have trauma to the chest due from the seatbelt, steering wheel, dashboard, anything like that can cause those extra traumas that we need to really concentrate about. Primary assessment, focus on identifying and managing all life threats. We are going to address bleeding and treat for signs of shock, because we know if we don't fix that early, it's gonna bite us in the butt. Check for all responsiveness. Use our AVPU. Use our. We go to talk about histories. We can use all these mnemonics, but we got to use them at the right time. And then again, check for responsiveness using the AVPU scale. We just want to know what the patient's chief complaint is. And at the same time, when we ask these questions, sorry, 2 a.m. was a long time ago. We want to know exactly what they say is wrong with them. Administer high flow O2, we know we should be doing that on everybody. It could be by the needs of a back valve mask, could be just by a non-rebreather or a nasal cannula, but we want to provide that flow of oxygen. We can ask about our MOIs, but really, we just need to know it for our records. We can tell the facility, this is what we come across, this is what we found. If there's significant trauma to multiple body systems that are affected, the musculoskeletal injuries may be at a lower priority. So think about those too. We see there that most of the time, sprains and fractures don't really create airway breathing problems. But again, it could be due to their chief complaint and mechanism of injury. Always ask those questions if they're having any trouble breathing. Are you having any shortness of breath? Are you notice any trouble speaking and breathing at the same time? Some people will tell you yes on a normal basis just because that's just people. Focus on determining whether your patient has a pulse, they have adequate perfusion, or is bleeding. If their skin is pale, cool, and clammy, that is an automatic indication for shock. Treat it. Maintain a normal body temperature no matter what it is out there. If it is 900 degrees outside and your patient says that they're hot, you have to accommodate them to keep them in a stable position. Stabilize injuries to the extremities prior to moving the patient, because if not, it's going to create just a lot of pain, discomfort, and now when you as a provider can at least provide some assistance, and you're not, that's neglect. If we can do any type of movement, bandages, or support prior to movement, well, let's take that extra time and do it unless it is a life over limb matter. If it's something that we're worried about their life, we need to move them immediately. If it's something that we don't have to worry about, let's stay right there, fix them, package them, get them up, ready to go. But life over limb, we can always jerk them out of the way and get them going. Our transport decisions, it's simple. Do we need to stay and play, or do we need to load and go? Those are the things that you as a provider need to make those decisions when you're ready. When you're out there on your truck, be like, look, I think this, I think that. You need to have that mindset of whatever GCS that you're comfortable with on any particular patient. If you're like, hey, look, 11 and below, I need to load and go because I'm so new in this. I don't know on my GCS scale. Some patients at the bottom pinpoint there, it says that some patients with an MOI may be further assessed and their condition stabilized on scene prior to transport if no other problems exist. So again, just because the MOI looks to be serious, we need to treat that patient as a potential serious, even though that they don't show any injuries. We want to go get them checked out. They need to have a clean bill of health, or the best cleanability of health that we can assist them with. On our histories, every single patient, you should be obtaining a medical history, period. You want to do a sample for all your trauma patients. A sample is also good for just your regular medical patients. What's to say? OPQRST is too lengthy when ABCs require immediate attention. That is correct. You need to fix your ABCs before you should be diving off into the history of this patient, period. And once you understand that their ABCs are fixed, then you can move forward. It's not one of those that you just need to sit there and wait. No, we need to get this ongoing. Their ABCs need to be fixed so we can handle that before we move further on down the road. Because if you don't fix them, they're gonna pass and it's over. What to say? If significant trauma has likely affected multi-systems, start with a secondary assessment of the entire body to be for sure that you have found all the problems and injuries. So if you see the patient is obvious, has multiple systems, do a detailed assessment as you go through this patient. I do recommend that you start at the head, work your way down, because if they are having, any type of airway, breathing, and circulation, you're starting off at their head. That's where 99% of your oxygen comes in. So let's start there and work our way down. Again, I keep telling y'all, see on the bottom bullet, y'all use your DCAP BTLS. It is very familiar. It's very common. You get so used to saying DCAP BTLS. It's a very healthy acronym to learn. When lacerations are present in extremity, an open fracture must be considered bleeding controlled and dressings applied. Any injury or deformity of the bone may be associated with vessel or nerve injuries. We want to attain a baseline neurological assessment. Always recheck the neurological function limb before and after you splint or otherwise manipulate that limb. Examination of the limb should include the 6 P's of musculoskeletal assessment. That 6 P's are pain, paralysis, parenthesis, which is numb or tingling, pulselessness, pallor, and pressure. And again, you see your bottom bullet, determine your baseline set of vitals. Reassess. Top 2 is your most important thing. Reassess every 5 minutes for an unstable, 15 minutes for a stable patient, and you want to reassess your vitals anytime that you've done something to them, like a treatment. We want to make sure we reassess that to make sure that it is upholding on the end that we provided, that it is working. If it is not working anymore, let's adjust that and get them on the right side. When you do your reassessment, this must be done en route to the hospital. That's not something that we're waiting on. Unless it is an extended circumstance, as in extended extrication, extended patient access, those things can and will delay you. So we need to make sure we pay attention to those. If the patient has no life-threatening injuries, you may take extra time at the scene. After assessing the extremities, apply a secure splint, commercial or otherwise, a stabilizing to the joint prior to transport. If you have anything, you may use a leg splint to where you can get them in a better position. If it's been a femur fracture, anything like that, those longboard splints were very, very helpful. Communication documentations. If you did something, you have to document it and you have to report it. You have to report it to the medical facility, and then you have to document it and report it on your EMS charts, because 10 years later down the road, you're going to be like, I don't remember what I did on that call. There's a lot of calls that I can remember that poke my head and my memory flexes and I'm able to, to recall things. But a lot of times I have to go off of my documentation. Performing in primary assessments, we stabilize your patients. If need, perform a secondary assessment of the entire body or the specific area of injury. Be alert for signs and symptoms of internal bleeding. Vital signs will show you that too, depends on how well you monitor those. Talked about splinting. Splinting is a flexible or rigid device that is used to protect and maintain the position of an injured extremity. Unless the patient's life is in immediate danger, you should split all fractures, dislocations, and sprains before moving the patient. Reduces pain, and it makes it easier for transport and transporting the patient. The patient will thank you if you're able to help get some of the pain from them. A lot of times it happens with elderly where they slip, trip, and fall. So those are the ones that we have to make sure we take our time with them when we talk about hip injuries. Anytime there's a broken bone, let's make sure we splint it very well and then get on the right path. You see right there, those bullets. I'm gonna let y'all read that real quick. I'm gonna swallow some drink. So general principles right there. Note and record the patient's neurovascular status distal to the site of the injury. What that means is I want you to make sure that you have a pulse prior to splinting and post splinting. Anytime that you go to splint anything, you get the one chance to potentially move it, splint it in its normal anatomical position, if it's not already, and check for a pulse then. If no pulse, then you have to leave it where it's at. Do not move the patient before splinting. We talked about that a while ago. And a suspected fracture of the shaft of the bone. Be sure to stabilize the joints above and below the fractures. That just helps you with your patient care as you go to move and transport that patient. If they're in a lot better comfortable position, that injury has been semi-fixed. So that's why we want to make sure we splint them first one before we get ready to move, because it helps things around. With injuries in and around the joint, we talked about that, stabilizing the joint above and below. Add all rigid splints. If you have a void space, let's say you're padding the arm, and you want to repad everywhere that is a voided space. You do want to try to maintain manual stabilization as long as you can. Now, when we say this, we can also ask the patient to help maintain stabilization if they're able to. Obviously, if they're out of their mind or they're unconscious or something else, they're not gonna be able to sit there and hold that. You just have to do your best at that point. If you encounter resistance to the limb alignment, splint the limb in a deformed position. So like I said, you have that one chance to move it. If it doesn't do it again, it stays where it's at. There's something bigger and better that's stopping it. So keep that in mind. When in doubt, always splint. It's easier to put it on and take it off versus it is you transport them and then get this, then get it splinted. Most splints are rigid. They applied from either a formable or a non-formable. When it talks about rigid, it's all applies to the sides, front, and back of an injured extremity. It does prevent motion at the injury site, and it takes two people to apply a proper splint, because you have to have one that holds everything once it gets it in place, and then the other one is to apply it, secure it, and then the other attendant is able to move their hands and or arm out of the way. Two situations in which you must splint the limb is when the deformity is severe, and then when you encounter resistance or extreme pain when applying gentle traction to the fracture of the shaft on the long bone. So if I'm going to apply a femur fracture and I'm supporting I'm pulling pressure on it. So I'm going to secure their leg and the contraption, and then I'm going to pull the separation of it and try to assist in fixing it. If you feel resistance, don't continue to pull, let it be. You're just gonna have to splint in place and continue to rock on. Some formable splints, we talk about the SAM splint, which is my favorite. I absolutely love a SAM splint. You can do anything and everything with that, so those are my favorite. We talk about air splints, pillow splints, sling and swath bandages, and other vacuum splints. Be smart about what you have on your particular service truck. Make sure you know where they're at. Make sure you do good inventory when you're there. If somebody starts to teach you how to where things are, just listen to them. Take as much information as you can. So when you're out there by yourself on that next day and you're like, oh God, I need a splint. I don't know where the splint is. Oh, you should have paid attention. Some pelvic binders, not many services around my area use these. They are aftermarket pelvic binders. They are very expensive. They are finally starting to come down and just make it more to where some of these smaller services are able to maintain those and put them on trucks. But if you ever get the ability to use this pelvic binder, you need to learn it while you can, because you never know where you'll be and you're able to have to put one on. I still like the old sheet method. That is a me thing. I know it's not one of those like, oh, well, how do you use the sheet? It's a taught process. So when you're at your camps, ask somebody, your instructor, your lead, to show you how to use the sheet binder. It's just all about how you wrap them up. It's like wrapping them in a burrito. Hazards of improper splinting. Obviously, we may have some compression issues. We're going to have some aggravation of the bones where they start grinding against each other. The injury is going to get very aggravated, start to swell. And what's to say, delay in transport of a patient with a life-threatening injury. So we have to think about all these things. And then once we get them to the facility and they're like, why didn't you splint their arm? Well, I mean, I didn't have time, like as in distance time, or you failed to do what you're supposed to do. So make sure you recognize it and splint it early. Again, if there's any questions, always splint, but let's not miss those if they're obvious or they're being complained about. Let's make sure we knock those out and get them splinted early, and so we can better move them and provide a better treatment for the patient, because that injury pain is not as severe at the time. Talk about transportation here. Just remember, when you go to transport and you're driving, that is bumpy in the back, man. I'm gonna tell you, it is very bumpy. That's not something that, it's not where nobody wants to be, but people are in those situations to where they're on backboards and this and that position for a hot minute, and you're coming down a very industrial area. And I mean, it's one of those that it's you don't want to be on a backboard, but if you have to put somebody there, just remember that. Make sure you pad them up very well. You get their information collected. So it's there's a lot of things that we can do to try to make this route better for them in transportation. So let's think about that on the front end. Specific musculoskeletal injuries, injuries to the clavicle and scapula. Oh my God, those are painful. A patient with a fracture of the clavicle will report pain to the shoulder and will usually hold the arm across the front of his or her body. So they'll hold it either in a 90-degree angle, or it will be like your upper shirt, if they're able to grab on. If they have a, like I call them pearl snaps, or a button-up shirt, put their hand in a 90-degree position and let their hands rest on the inside of their shirts until you can get like a sling and swath, or can secure it in any form of fashion. The fractures of the scapula or shoulder blade occur much less frequent because of the bone, as well as protected as many large muscles. So it is associated chest injuries, not fractured scapula, the purpose of the great threat of the long-term disability. So we have to be cautious about that. Some abrasions, contusions, and significant swelling may occur, and the patient will often limit use of will limit the use of the arm because of the pain to that fracture site. So again, they're not going to want to be stretching, moving, swinging, anything like that because of the massive pain. Here's a picture of a sling and swath. You can use those on most every ambulance in the States, lower 48, have to carry sling and swaths. So it's one of those that you may come across it at your facility. So when you go to train and you do all this, just make sure you pay attention when you're looking at how to do this sling and swath. I know that they'll teach you, but at the same time, we need to be very attentive because that's our time to learn. And let's make mistakes when we're in there learning, not out in the field. So a dislocated shoulder is very, very uncomfortable. The humeral head is the most common dislocation anteriorly that comes to lie in front of the scapula and is a result of forced abduction and external rotation of the arm. Stabilizing an anterior shoulder dislocation is difficult because there are many steps associated with the arm in towards the chest pocket of the wall. Let's see here. Transport the patient in a seated position. We want to try to sit them in the most position of comfort. Remember when we go to sit them down or ease them up, that they can't reach out and pull, and you don't need to pull on that injured arm. If it's their primary arm, be understanding that they probably won't be able to do a whole lot. So you're going to have to help them out until you get them into the medical facility for them to be able to sign anything. Let's see here. Occur either, fractured humerus occur either proximal or in mid-shaft or distal to the elbow. With a severely angulated fracture, it should consider applying traction to relieve the fracture segments before splinting them. Support the site of the fracture with one hand, and with the other hand, grasp the two humeral condyles just above the pillow. Splint the arm when a sling and swath, supplemented by a padded board splint on the lateral aspect of arm. Fractures and dislocations is, there's a picture coming up. It's kind of gross, but I'll show you one. It's not super, super bad, but all different types of injuries are difficult to distinguish without any type of x-ray. They all produce similar limb deformities, and they require the same emergency care, which is out of our protocols and out of our realm, but we can provide them some medicine to stay feeling better. This type of fracture is also known as a subcondylar or intercondylar fracture. If y'all can pronounce that, that's on your screen, but that is very common in children. Frequently, the fracture fragments rotate significantly, producing deformities and causing injuries to the nearby vessels. Swelling occurs rapidly and is often severe. There's your dislocation. As you can see, he's in severe pain. It is very uncomfortable. This type of injury typically occurs in athletes and rare in young children. The ulna and radius are most often displaced posterior relative to the humerus. Posterior displacement makes the olecrayon process of the ulna much more prominent, and there is swelling and significant potential for loss of nerve injuries. You think that's not supposed to be in that position, I can promise you, boys. Let's see here. Fractures of the olecrayon process, those I just read that. So fractures of the radial head, they are often missed. Most of the time you don't get a x-ray of the particular head or lower joint, just because that's something that's typically done. Generally occurs as a result of falling onto a stretched arm or direct elbow to the lateral aspect of the elbow. Attempts to rotate the elbow or wrist causes much discomfort. So on this fella right here, we're gonna give him one chance. We're gonna try to rotate it. If it doesn't go, we're just gonna splint it in place and transport him to the correct facility. Some injuries to the elbows. These are probably going to be misdiagnosed a lot of times because we're just going to be bypassing that area as we're looking for other injuries. So we need to be cautious about that. Again, attempts to rotate the elbow or wrist causes very much discomfort. Care of elbow injuries. An elbow injury are potential serious and require further careful management. Always assess digital neurovascular functions periodically in the patient with an elbow injury just to make sure that that pulse stays in place and that we're able to feel it on the fly. A cold, pale hand or weak or absent pulse and poor capillary refill can indicate that the blood vessels have likely been injured. Provide prompt transport for all patients with an impaired distal circulation. Fractures of the forearm, seen most often in children and older people. Usually both bones break at the same time when an injury is a result of a fall and an outstretched hand or arm. That is very common. Fractures of the distal radius, which are especially common in elderly patients with osteoporosis, are known as colloid fracture. To stabilize fractures, where did I just read that? To stabilize fractures of the forearm or wrist, you must use a padded board, air vacuum splint, or a pillow splint. Anybody have any questions so far? We have to have x-rays to determine if there's any type of fracture there. Another common wrist injury is isolated, non-displaced though, but fracture of the carpal bone, especially the scapuloid. Because the fingers and hands are required to function in such intricate ways, any injury that is not treated properly may result being permanently disabled and well as deformed. Let's take a quick little break here. Take another 10 minutes. I need to do something real fast. I show 7:32. I'll see y'all back at 7:42. All right, folks, we don't have that many left over. So there's just a few and then we'll continue for tonight. So fractures to the pelvis. These are going to be life-threatening. We can hold a lot of blood into our pelvic area. They may be accomplished with life-threatening injuries. We know that because the pelvic is at a key point where all the vessels come into. Up to several liters of blood may drain into the pelvic space between the abdominal cavity and the posterior abdomen wall. Things will happen to sink in, sit there. It can result in significant hypotension, shock, and death because of the massive fluid loss. Pelvic fractures can lacerate the rectum, vagina, and bladder. So be careful if you suspect those things. Know that there also may be other fluids that will contain up into the body cavity and potentially cause infections later down the road. So when we check our vital signs on a regular basis, we should potentially notice that we have some changes going on. Those changes we need to make sure we're attentive to and that we document them through the process. Suspected fracture of the pelvis and any patient who has sustained a high velocity injury and complains of discomfort in the lower back or abdomen. Deformity to or swelling may be very difficult to see. The most reliable sign of fracture of the pelvis is simple tenderness or instability on firm compression and palpation. Assess for any type of tenderness. Patients in stable conditions can be secured to a long backboard or on a scoop stretcher to stabilize isolated fractures of the pelvis. So here's how we check the pelvic growth. We can do the iliac crest. We're going to push on the top, on the bony part of the iliac right in here. We want to push inward on both spots. Then we want to press down on the pubis symphysis, checking that. And then you can do the pelvic shift where you can try to push down on the pelvic symphysis on either side. So what you're doing is checking to see if there's any breaks here and down in here on those movements. They will tell you pretty fast if there is. So don't be like, oh, well, maybe just a minute. No, they'll tell you like instantly. So be careful and cautious of that. Dislocation of the hip. A hip is very stable. It is a ball and socket joint that dislocates only after significant injuries. The biggest ones that we'll see is like slip, trip, and fall. You will also notice it when they have the biggest sign that you'll see on that is a reduction of one of the hips, the leg. So if you have them laying flat on a surface, one of these legs will be shorter and rotated to the right and or left, depending on what leg it is. I was trying to send a message. Most of the dislocations of the hip are posterior, most commonly occurring as a result of a motor vehicle crash in which the knee meets with a direct force and the entire femur is driven posteriorly. So remember those when we talk about a dislocation. If you notice that their feet were propped up on the dash, that is part of the problem that we may suspect several multi-system traumas there. So a posterior dislocation of a hip injury is a very distinctive sign. It is a very severe pain, as resistance to movement, tenderness on palpation, and the ability to palpate the femoral head deep within the muscles of the buttocks. You do have severe tenderness. The patients do not like to be moved much. They want to stay in one place and be situated from there. They will tell you that there's a lot of discomfort. As with any other extremity injury, do not attempt to reduce the dislocated hip in the field unless medical control directs you to, which is going to be very, very, very rare that they do that, if at all. Splint the dislocation in the position of deformity and place the patient supine on a long backboard. Support the affected limb with pillows and roll blankets and secure the limb to the backboard. And the reason why we do that is just to secure them. We want to make sure that when we go to move them, that particular limb is not like unsecured and falls off the stretcher. That's not going to be cool. That's not how we need to move these patients. We talk about fractures to the proximal femur. So fractures of the proximal end of the femur are common fractures, especially in older people and patients with osteoporosis. The break goes through the neck of the femur, which is, oh, that's got to be painful, into the inner thoracic region and across the proximal shaft of the femur. Patients display a very characteristic deformity. They lie with the leg externally rotated, and the injured limb is usually shorter and then the opposite uninjured limbs, what I was telling you about a second ago. Patients typically are unable to walk or move the limb. They're not going to walk, I can tell you that now. The hip region is usually tender on palpation, and gentle rolling of the leg will cause pain, but will not do any further damage to the patient. Assess the pelvic for any soft tissue injuries. You want to feel for any type of warm swelling to the area. We want to be attentive for color change. Splint the lower extremities and transport to the emergency department. Patients may have a significant blood loss due to the area in the limb is able to hold a lot of fluid. We are going to treat with high flow O2, monitor vital signs, and be alert for signs of shock. We can do things about treatment of shock in the field. Now, just because we recognize that they have, they're going hypotensive, we can't fix that really in the field without having ALS there. We can give ALS our findings and let ALS go further and help fix it. But we as basics can't make that fix. We are unable to fix that in the field. For more shaft injuries, we talked, the biggest thing here is a large muscle of the thigh spasm. As it tends to splint, it is very discomfortable. There's oftentimes significant blood loss. You'll notice that into the swelling of that particular limb, and it is very warm. Let's see. Because of the severe deformity that occurs with these fractures, bone fragments may penetrate or press on important nerves and vessels and produce significant damage. We want to be careful and periodically assess the distal pulse in these patients. Cover any wounds with a dry sterile dressing in case there is an open fracture. A fracture to the femoral shaft is best stabilized with a traction splint and basically just like a Sager splint. There's multiple ones out there. Sager has kind of done the tried and true, and there are the main one that we go to these days. Most providers, because they do the job and they're very simple to operate. That's why we like them. Traction splints. They are used primarily to secure fractures to the shaft of the femur, which are characterized by pain, swelling, and deformities of mid-thigh. Excessive traction can be harmful and injure to limb. So what are goals here? When we want to do the goals of an inline traction, obviously, as you see those 3 bullets, we want to make sure we stabilize it. We align the limb that it is in a inline anatomical position and prevent any other type of neurovascular compromise. So once we get them in this Sager splint, we get ready to start cranking it down to provide traction. We don't want to provide any more traction than is unnecessary. So if we give like 6 cranks, and then the patient's like, oh my God, this feels so much better. I always go +1, and then I leave it alone, I lock it in place. So, and I can tell the staff, hey, I gave 6 cranks to the traction +6 +1, and the patient has stayed in a comfort position in the entire time of transport. Now, they are, I mean, it is obvious they're in pain. As soon as you start providing traction, and they're like, oh my God, that feels so much better. That's because it's taking that pressure off of them. So always note that, and that is our sign that our traction is in place and at the right time. I mean, at the right location. Do not use any of these in any of these conditions. Obviously, injuries to the upper extremities, we don't want to do that. Injuries close to involving the knee, injuries to the pelvis, partial amputations or avulsions with bone separations, and lower leg, foot, and ankle injuries. We splint those the best ability that we can, but we have to be very cautious on how we splint those so we don't, due to its location, we could potentially cause other neurovascular injuries. Injuries to the knee ligaments, we can have a lot of these happen just walking down the street. Ligament injuries, dislocated patella, bony elements can fracture. The patella can very much dislocate. All the bony elements of the knee can be fractured. So these are other different types of injuries in that region. The knee is especially susceptible to a ligament injury when occurred with abnormal bending or twisting forces are applied. We know that they're only supposed to go one way. The patient will report pain to the joint and be unable to use its extremity normal. Swelling, bruising, tenderness, and fluid in the joints are generally present at this point. You should splint all suspected knee ligament injuries. The splint should extend from the hip joint to the foot, stabilizing the bone above the injured joint and below the joint. A variety of splints can be used, such as we talked about this a while ago. We have our padded splint, our rigid, our long leg splints, and then we have our two padded board splints. We can use cordboard splint. We can use KED. We have all these other assets to use. It just depends on what your agency provides as their of their choice. A dislocation of the knee, that is a true emergency. That is potentially injury and a life-threatening injury to the limb. Always check the distal circulation carefully before taking enough steps. Make sure that they have a pulse in that limb, or if they don't, we get the ability to move it once to try to put it in an inline anatomical position to try to reobtain a pulse. Posterior knee dislocations are the most common, occurring in half of all cases that we see with knee dislocations. Medial dislocations result from a direct blow to the lateral part of the leg. Patients will typically complain of pain in the knee and report that the knee just gave out. And inadequate distal pulses are present. Splint the knee in the position in which you found it and transport the patient very promptly. Med control may instruct you to attempt to realign the disc form, like I told you before. The pulsus limb to reduce compression of the popliteal artery, and you potentially can restore distal circulation. So that's a good thing. Make sure you relay that to med control. Let's see here, fractures of the knee. If there's adequate distal pulse and no significant formation, splint the limb in the position of straightness. Let's see here, never use traction splints if you suspect a fracture to the knee. If the pulse is absent below the level of the injury, suspect a possible vascular and nerve damage and contact med control ASAP. I talked about that. Let's talk about ankle injuries real fast. Ankle injuries are commonly joint injuries. Ankle injuries occur in people of all ages. I've broken both of my ankles 4 times. Any ankle injury that can does produce pain, swelling, localized tenderness, or the inability to bear weight must be evaluated by a physician. A lot of people don't want to go because they just think they sprained it. It could easily be a fracture and or a break to the ankle. The most frequent mechanism of ankle injury is twisting, which stretches or tears the supporting ligaments. Dressile wounds you see on your screen there. Before releasing traction, apply splint. Correct any gross deformities by applying traction, and they'll get your attention. They grow. So let's look at this one. So we see a lot of people that fall. So the force of the injury is transmitted up the legs to the spine. So you see all these people that jump and do all these building jumps and they land on their feet, or they jump from very high areas and they land. Those can potentially also cause a compression fracture of the spine. They can cause severe damage to their body, knees, joints, ligaments, and all that stuff that can be torn. When you get there, you need to ask what the mechanism of injury is and what happened when they created this issue. So be thoughtful about that. If you notice that there is a compression fracture, there may be some metatarsals that are broken. You may have some phalanges or their little toes that are broke also due to that, but also be very particular about looking at their lumbar, that there may be a fracture to the lumbar spine that may have a blown disc. So inspect their back at the same time too. If you suspect that the foot is dislocated, immediately assess for a pulse and motor sensory functions. If pulses are present, immobilize the extremity using a splint, leaving the toes exposed so you can check them later. When the patient is lying on the stretcher, evaluate the foot approximately 6 inches to minimize swelling. We want to try to raise it up as best as we can. We don't want to put it up high, super high, but we do want to try to elevate their extremity. So like he says, like we can potentially reduce any type of swelling so we don't have any vascular fill or overflow due to the injuries. Strains, we have RICE. That is the biggest thing that all people go with is rest, ice, compression, evaluation, and splinting. Though elevation, we're not good evaluation. Wow, I can't even read. So the RICE is our acronym when it comes to strains and sprains. And then we'll hit amputations. The biggest thing we can do here is control bleeding and treat for shock. Surgeons today can occasionally reattach amputations. That is occasionally. It depends on how long, where it was taken at, and is there much blood that's been amputated or nerve damage injuries. With partial amputations, make sure to mobilize the part with a bulky compression dressing and splint to prevent further injury. Control bleeding from the stump. We want to make sure that we pat it very well, secure it, and make sure that they are taken care of. Right here, with a complete amputation, wrap and go in. Everybody hear me? I guess I just got kicked off and right back on. Can y'all? So we got kicked off real quick. Somebody show me that y'all can hear me. Okay. Yeah, I don't know what happened. That was like my whole screen just blinked out. So amputations, applying the patient's name and everything to it is very important. I was at a particular company. We had an amputation, transported the patient. It was done textbook. We come back the next day when I was doing a 48-hour shift up there, and they actually reattached the amputation to the wrong side of the patient's body. So that wasn't cool. That turned out to be very bad. That was a hospital paid a lot of money for that. So anytime that we have a injury, we can have a compartment syndrome. Compartment syndrome is a limb life-threatening condition characterized by localized tissue swelling within the compartment. This does typically develop within 6 to 12 hours of the injury. Blood flow decreases inside a muscle compartment. Ischemia results in an anaerobic metabolism results. Tissues become damaged and can die from this. Definitively, treatment is a surgical procedure called a fasciotomy. An incision through the skin and fascia allows the swollen muscles to expand, reducing pressure inside the compartment. Compartment syndrome typically develops, like I said, 6 to 12 hours. It results from excessive bleeding. You have that information on your screen. Symptoms, signs and symptoms include pain that is out of proportion to the injury, pain and passive stretch of the muscles within the compartment, and an altered sensation. Additional signs may include pallor and decreased power to that particular area. It is something that we may not see in the field. We may see the backside. Is everybody still able to see my slides? I'm noticing that y'all aren't. Oh, how about that? Is that better? Are able to see them now? Better. I'm so sorry, y'all. I don't know what happened. I guess my internet went out. Got exactly what my main thought was going on. If you suspect the patient has compartment syndrome, splint the affected limb, keep it at a level of the heart, reassess neurovascular status frequently during transports. Rodney, this is it. That is actually the last slide. So before I give y'all the class code, I need to ask you guys some questions. So the next couple of chapters are lengthy. They are long. Some of them will potentially take 2 nights to complete. Our completion date is supposed to be May 3rd. Now, here's my question I want to ask you guys. Do you guys want to extend past May 3rd to get these classes, or do y'all want me to potentially record, do a class one night, the next day while I'm at work when I can, I'll record the second portion of it and let y'all listen to it and go through the class. The reason why I asked that is because I will not be here to teach May 3rd or the 5th. I will be out of state and out of pocket due to some training that I must attend. So the question that is up to you guys, what you would like to do, your majority of the class. One is we extend the class and have split the next few chapters up into 2 nights. That would push us into May 10th, 12th-ish, or we can keep it where it is and I can teach the class. The next day I record the second part and y'all will be able to listen to that and take your test accordingly. What do y'all want to do? You're saying, so just using for example, you're voting for teach the class on Thursday and then I can turn around and record it on Friday and y'all can listen to it and take your test after the 3rd day of the second class. How's that? Is that what you're saying? So, all right. And then hang on, I'm seeing Nathan says you want option 2 to extend the class, continue as scheduled and finish as originally planned on May 3rd. Okay. I can do that. That I was kind of hoping that was my suggestion. This is the end of the program. Y'all will be having also a module exam open up, and then you will a couple other classes, and you will have your final exam. There's several of you that I don't know why can't remember, comprehend, but your test has to be done within 3 days. Several of y'all have not taken many tests at all. I don't understand why, but your class opens tonight at 10. Some of y'all need to stay up and take those tests because y'all are very, very behind. Some of you are not. Some of y'all are on point, your own times. Your grades are current on JB Learning. I have corrected those as of today. Some of you need to answer on some of the other emails that we have corresponded with. I'm not going to sit here and babysit everybody. It's not my job to track up things that y'all are missing, but if y'all want to pass the program, y'all need to get on with the program. But as of now, we will keep the same schedule. We should shoot to finish on May 3rd. I will teach a class, record the second part, and I will adjust the test dates accordingly depending upon the class. I will keep everybody informed. Does anybody have any questions about tonight, any tests? How do we access the grade? I can never find an actual grade. I don't know that because on my screen, I'm able to click grade and I can see everyone's grade. Does somebody know how to answer that question? I never get to see it from a student's point. Oh, we can see our grades, but not our average. Okay, so if somebody would like, you're more than welcome to message me on Discord, and I can tell you that. That is very easy. That's easy. I can tell y'all that. But it may not be till tomorrow because I'm extremely tired. I've been up since 2 a.m. this morning. I couldn't sleep, and I'm tired. So if you would like, I can give you your average currently, but that'll probably be tomorrow. So that being said, here is your class code for tonight. That is how you should enter to get your attendance for tonight.
Hello, Mr. Chris, are you there?
No, I don't know what happened. I guess I just got kicked off again.
Okay, can you hear me?
Yes, ma'am.
I just have a quick question for you. For the grades on JB Learning for the quizzes and tests, when I went back to look, it has it recorded when I click on the quiz, like to see if I completed it. It has the grade recorded on there, but when I go to like the grade sheet, with all the overall grades, it shows a bunch of zeros for a couple of them.
Hang on, I got it pulled up. Let me go pull this up real quick so I can look. This is Sydney, right?
Yes, this is Sydney Clark.
Oh, come on. Dang, act right. Hang on, I have to. It's not acting right for me tonight. Sydney. So you never took chapter 3 in the beginning?
Yeah, well, no, I'm talking about the more recent ones, like the ones for like the last 2 weeks, I want to say.
So I don't show that you ever took 27, 28, or 30.
Yep, I took 30. Because I'm looking at it right now. I took it twice when you reopened it just to see if something new will pop up. Like on my end,
Yeah.
it shows 2 grades for it.
Well, what'd you make?
And like I made a 90 and I made a 100, and the same thing for 29 and 28. If you want, I could take a picture of each one and email it.
I show 29 that you made a 90 on my
Yeah.
side. Oh, hang on, I don't know what happened. I show, the only thing I'm missing is 27, 28.
And what about 30?
30, you have 100 in there.
Okay, now let me see. And you see you
You
missing
showing any
27?
grades? 27 and 28.
Hold on. I'm going back to it right now. Okay, for 28, I took it twice as well. I got a 100 on the second attempt.
Okay.
And now I'm going to 27. Let me see. Uh, 27, I also have a 100 for it, and I did 1 attempt.
Keep hitting the enter button and can't even write nothing down.
Quick question: Does that commonly happen with JB learning?
So JB is very, very particular. A lot of times, I can go in there and manually put a grade in, and then I can go in there and undo it and let them put their grade in, and it still will not accept it. So sometimes there is those issues.
Okay. Okay. Well,